Okay, so apparently the program that I have is a free version. It cuts me off at 30 minutes, and we only got 20 questions in 30 minutes. But I mean, that's like 90 seconds a question. I'm gonna try to go faster because that's the entire purpose for this. Okay, so we went over 22. Okay, I did go over 22, but it wasn't getting recorded. And I have my timer here. I'm going to time myself better this time. So basically, what you have here is pain that radiates to the back, a little bit of fever, a little bit of tachycardia, and has no medical history, right? That means, and so basically, pain radiates back to the back is the description of pancreatitis. Is your pancreas. It's retroperitoneal, so you get pain, epigastric pain that radiates to the back. It kind of eliminates everything except for A, and it's kind of also an acute cause, so it can't be like a duodenal ulcer that ruptures onto the pancreas. Okay, so the answer for this is A. Uh, so this one basically, a 35-year-old girl she's hypothyroidic but has high TSH. There is cervical lymphadenopathy. The thyroid isn't tender. The fact that it's not tender is not decluvian or giant cell thyroiditis, which is what E is trying to refer to. Soma bodies, it's not cancer really. Exophthalmos, it's not hyperthyroidism. Elevated calcitonin is seen in uh, the parafollicular cells, I think. Yeah, but it's not. It doesn't have anything to do with what we're talking about here. So that's A. So 34-year-old woman, discomfort during intercourse and placing tampons, no fever, everything else is normal, pressure is normal. Uh, Swollen. Oh, okay. So she's got a bunch of pain and then posterior lateral part of the vulva. So let's try that. So if this is vagina, it's posterior lateral, so it's here or here, and this is like front, this is back. Let's see, this is the anus here, right? So our inflammation is here. This is a description of where the Barthelion cysts are. So that's A. 25. Okay, 48-year-old, nausea, pain. She's she's lost 8 pounds, 9 pounds. Sorry, 8 kilograms. They're around 9 kilograms. Uh, over the past 4 months. Does a GI endoscopy. There's kind of an ulcer lesion, and so it's kind of a stomach cancer type situation. There's atypical glands containing cells with enlarged hyperchromatic nuclei, right? Below the muscularis mucosa of. So, okay, atypical looking nuclei, tripolar mitosis, mitosis is bipolar, it's tripolar. It's just weird cell shit. So it's cancer. But what we gotta think of is which type of cancer now. So remember, there is intestinal and then diffuse type. Intestinal is because of abuse, is because of I mean, abuse being mostly E. coli. It's because of stress. It's because of nitrosamines, like nitrate containing stuff. It's because of anything else. And the diffuse type seems to be kind of random and it has the worst prognosis. And then the other thing is the diffuse type gives you two things. Um, is the plastica thing, so it invades the stomach, makes it super thick, and the other thing is it has single cells, so it has these cells with a lot of mucus in them, and then the nucleus is on the side, right? And this thing can metastasize to both ovaries, right? So you get ovaries with like mucus like mucin producing like tissues, but it happens in both ovaries, and that's the key, right? If it so that's how you know it's not a cancer of the ovary, it's cancer of somewhere else that's metastasized to the ovary. And the way it metastasizes, it's not hematogenous or through lymph. It's called seeding. It's through the peritoneum. It's one of the special cases we learn in oncology, and this is a good example of that, right? So basically, this girl has like no single ring, so it has the intestinal type. The intestinal type, risk factors I said, like most commonly is sources of stress, but most commonly E. coli, right? E. coli ulceration. 26. Man, I got. Oh, I didn't get. Interesting why I got this one wrong. 42-year-old, 5-month history of weakness, low blood pressure. Okay, why would someone have low blood pressure? Maybe they're losing cortisol. I don't know. Dark appearing pulmonary, kind of gives me that. So you have low cortisol, your HCCH goes up as a reaction that causes increasing melanocyte stimulating hormone. Then you get darkening of the skin. Serum sodium is low. That also indicates you have like kind of low aldosterone, although aldosterone is more regulated uh, with angiotensin 2. So the sodium is low, potassium is high. Yeah, so you have low. So you have low mineral, gluco, and that's it, right? Mineral and glucocorticoids, and ACTH is elevated. So for some reason, your adrenals aren't responding. Um, so that's basically an adrenal insufficiency. Now, is it primary, tertiary, or whatever? So basically, there isn't. So primary adrenal insufficiency is also called Addison's disease. Primary means the problem is with the adrenals themselves, right? Secondary means the problem is with the pituitary. Tertiary is for people who are on a high dose of corticosteroids. Let's say if someone has cancer, it's on a massive, massive dose of corticosteroids, and then they stop it because they got used to that high dose. Then, like all of a sudden, stopping it will give them like an adrenal insufficiency. So Addison's disease. There's a reason I got this wrong. Because like, what the hell is primary adrenal insufficiency? Why is it not an option? But I was like, duh, that's Addison's disease. Hey, all right, we got even 7 minutes. Fucker's slow. All right, 42-year-old, neck mass, hoarseness of voice, diarrhea, phenochromatocytoma. So that's a tumor, right? Neck mass is a tumor, so some sort of tumor predisposition. Um, and then there's the tumor in the neck basically has arranged in nests and uh, parafollicular protein. So there is also protein that's absent. This is a description of uh, medullary thyroid cancer. So this person has MEN, multiple endocrine neoplasia, and that's why it has phenochromatocytoma. Remember, there's when 1, 2A, and 2B. The description for this. So we got phenochromatocytoma. We got uh, kind of like a medullary. So this could be either 2A or 2B. 2A is, I think, in addition to these, has uh, I think it has parathyroid adenomas, right? 2B has mucosal neuromas, and 1A has phenochromatocytoma, pancreatic tumors, and pituitary tumors. If I'm not mistaken, I could be wrong about one. About one. Okay, I don't know if we went over this in lecture. So we got a tumor that's kind of like avoided by reference. So we got amyloid formation. So this is a medullary tumor for these reasons. Yeah, one, um, we have it's kind of describing cells arranged in a nest. That's kind of like trying to get to you at that these cells are like neuroendocrine cells because remember the arranged in a nest, kind of similar to carcinoid tumor. But they used to be believed that these cells are neuroendocrine cells, but they don't think they're neuroendocrine cells. They think they have an endodermal origin, so that's kind of an old point. But disconnected my monitor. Back up. Okay, so that's the first point. The second point is that it's talking about the amyloidosis. Amyloidosis happens as a result of calcitonin that goes around these cells. So if they give you a picture of like a bunch of cancer cells and there's like pink stuff around it, it's probably uh, medullary thyroid cancer and it's calcitonin you're seeing. I showed this one too. Okay, so this is an easy question. Basically, it's describing a person with phenochromocystoma and saying, okay, we give him a medication to do right before the surgery, and what is it? So it's phenoxybenzamine. But so the reason for that is you give phenoxybenzamine is because when you're removing the tumor, you're probably gonna move the tumor around, and this tumor is full of like uh, and like catecholamines, and a little bit of that gets into the blood. It destabilizes the patients. So you want to make sure you stop any of that from happening with a phenoxybenzamine that is irreversible. Okay. And remember, phenylephrine is like does the opposite, and octreotide is somatostatin analog, so it stops secretion, stops basically mainly if you want to think about it, stops secreting stuff. And labetalol is beta and alpha 1 antagonist. Okay. Okay, 4-year old. Let's get going. I don't want to lose time. 4-year old. Okay. So yeah. So she started having digestive problems after. Uh, Sorry, cereal, right? Uh, that just and then you got description of strateria. And the reason for strategy here, as opposed to one of the questions before, is that you will lose your like kind of like the surface area in the small intestine, so you don't have as much opportunities to absorb these fats. So you get them in your stool. You get that description. They can also describe it as stool that's hard to flush. So it says what else they can get. So it's a couple of things. Let's see, celiac is associated with IgA deficiency, um, and this, right? Dermatitis herpetiformis. If you remember, this was like if you have like this is your basement membrane, and you have like your epidermis. So there's like skin cells here, right? Uh, these guys were antibodies that are like accumulated here and kind of like gave this bump, right? Bump appearance. So this would be your epidermis. It's like this bump epidermis at the like the and like the skin here is like it goes up and down. So the peaks you get these antibody accumulations. Also review like the other disorders that look like this. It's pemphigoid vulgaris and bullous pemphigus. I don't want to review it now because I don't have enough time. So let's see. Yeah. So 8-year-old comes to the physician because of breast development. Okay, so she's a so basically this girl is 8, but she's had like the breast development, like the pubic area has more hair than what an 8-year-old is supposed to have, and it's asking you what it could possibly be. It's something that's secreting estrogen, right? It's something that's secreting something, and this really granulosa cell tumors are the best. Let's go over like so in the physiologic state, the granulosa cells are around the your your oocyte, right? It's surrounded in blue, and then you have T cells around this. These guys together they make estrogen. I think one of them makes androstenedione, and then the other one turns androstenedione into estrogen. See, oh wow, oh this one. So this is a really low quality photo. Basically, there's a neoplasm in the thyroid, right? Uh, what is it? And the picture that was shitty, so I gave you this picture. So I think what they want you to understand is like these stuff is like this is the orphan something whatever. The orphan Mary is like a little bit of whiteness in the nucleus not supposed to be there. So and that is what is the orphan represented by? I think it's God. Kind of look it up. Mm, guess you can look it up, but the answer to this one is papillary. I thought it was papillary because medullary is the one that has like amyloidosis. Okay, so which of the following is associated with this? Soma bodies, right? So cancers that have that have papillary structures, they will get calcification around these papillaries, and then papillaries die. So you get these like if you've seen pasoma bodies, they look like soma bodies. They look like this. That's like looking at this structure from the top. That's our eye. So you look at it from the top, you see this. Oh wow. Okay. So again, 16-year-old testicular mass, non okay, this is an actual mass. Chivar Duval bodies. You know, we went over this. Should all know this by now. You should all know this. So this is again the yolk sac tumor, and it produces alpha fetoprotein. Okay, this guy, and I should not show these. I forget what it was. I already forgot what it was. So 42-year-old Caucasian heartburn, has a hiatal hernia. Hiatal hernia is like if this is a diaphragm, the stomach is supposed to be like this is esophagus, and then stomach begins here. So if this happens like stomach like this, or if it's like this, it's like because of hiatal hernia, they can cause heartburn. That's all you gotta know. Uh, if you left untreated, you get heartburn. So you get what? You don't get squamous. Squamous is from up here. You get like whatever is down here. You get adenocarcinoma of the esophagus. So adenocarcinoma risk factor is like the acid damage that happens here. Everything else up here, all the sources of stress, warm drinks, alcohol, uh, esophageal webs, uh, tobacco, smoking, whatever, those will lead to squamous. This is E. All right, 44. We'll do 44 later. Because micro, I did it because I felt like I haven't done any macro yet, but I kind of knew what was going on. Again, this guy later. Okay, so 47-year-old woman, pelvic pain, examination shows adnexal mass, um, cystic masses in both ovaries. Both ovaries, oh my god. Yeah, that's why I emphasized it earlier. So you got mass in both ovaries. It could be a cancer that happened to happen in both ovaries, or something that spread to both ovaries, right? What has spread to both ovaries? It's the diffuse gastric cancer. Surgical resections. Okay, that's not the case. I don't think it's the case here. Uh, uh, okay, let's see. So you got masses in both ovaries, and then they are consensus of unilacunar cysts containing clear fluid. So the cysts are malignant looking. They're unilacunar, which means they're one cyst. They're not like multiple cysts. They're like kind of like all over the place. Um, the cyst is covered with oh, this is important, papillary outgrowth. So the if this is an ovary, the tumors that arise from the surface are three big types. The serous cystadenocarcinoma, the mesenchymal cystadenocarcinoma, and then the endometrioid one, right? And that's because of endometriosis, because there's ectopic endometrial tissue here. Now, the thing you gotta understand is that the serous and the mesenchymal cystadenocarcinomas, the reason they're there is that they're kind of like they're morphing into it's not so the epithelium on the ovary is not supposed to be serous or mucinous. So these cuboidal normal looking cells are turning into cells within the endometrium or the fallopian tubes, right? So the fallopian tube cells have serous. These are the serous cells. Uh, these guys are the mucinous cells. Okay, so this guy is looking now. Which one of them has papillary outgrowths? If you remember, what happens is that these guys have a lot of papillary outgrowths, and they kind of like propel the ovum into like here. So it's kind of saying that it looks like these guys. So it's probably gonna be like act like these guys, which means it's gonna be serious. Uh, but no, this wasn't the gastric cancer question that I thought we saw here earlier. Okay, 57. Okay, we've been in this 20 minutes. Let's see how many more we can get in the last 10 minutes of this video. 21-year-old, abdominal vaginal bleeding, so left-sided abdominal pain. So it's got, so when you see this, you can really, HCG, you can think of two things: malignancy or pregnancy. Uh, and you also see the yolk sac in the patient's left fallopian tube. So she's ectopically pregnant in the fallopian tube. Which one of them, oh, is a predisposing factor? So the answer to this is D, and this is why. You got your like cervix, let's say, and then this is a bad way of drawing it. You got your endometrium, right, and you got your fallopian bodies. So these guys, as I said earlier, will try to push like the ovum into the right place, which is around here. But if there is infection, if there is fibrosis of these guys, they can't do their job, and you get like the ovum will stay here, and you will get like basically you'll get pregnant here, and it's not the right place, so it'll hurt, it will bleed, it will burst. So what the biggest risk factor is fibrosis of this place, and what leads to that is uh, pelvic inflammatory disorder, kind of like any kind of disorder, like with gonorrhea or chlamydia mostly. So pelvic inflammatory disorder. So 55-year-old, 18 months history of progressive dystonia, both liquids and solids. So she can't eat liquids or solids, and spasm of the lower esophageal sphincter. So the way the lower esophageal sphincter relaxes is that the kind of the neurons that are responsible for the muscle part will relax, right? And in Chagas disease, that's what gets destroyed, right? So I mean, when you go over these basic points, and do you remember if it was Meissner's that was responsible for neurons, or was it Mayentrick, right? So Mayentrick is also, I think, Auerbach's. Uh, and then, so the way it works is that there's like these muscle layers and there's these mucosal layers. There's some neurons here. There's some neurons here. This is Meissner's. This is Mayentrick. Did I remember this? No. But what did I do? I looked at the names. If it's Mayentrick, sounds like muscle, and entric, so I thought this is probably the one that's responsible for the muscular activity of the GI system, and I was right. All right. Yeah, so this guy, basically description of 19-year-old, he was fine. He went over climbing, he got jaundice, and then you look at his blood work, his direct bilirubin is low, his total is high, which means you're not conjugating properly. This is a description of Gilbert syndrome, which is basically you are normal, but with stress because you don't have that UDP trans whatever enzyme. Uh, I think 7 UDP trans glucuronidase, whatever. You don't have that enough, then at times of stress, you end up having unconjugated hyperbilirubinemia. Okay. So this is a 64-year-old. Uh, yeah, so 64-year-old has a bunch of families, weight loss, sister had cancer, father died of cancer, sister died around 50. So, this guy, if assuming same stuff happens, he's at a lot of risk. Uncle died, so some sort of familial stuff. Upper endoscopy shows ulcerated mass of the lesser curvature of stomach. It's mainly caused by E. coli, but of course this can be a risk factor too. Lower GI is negative, right? Lower GI endoscopy, lower GI, that's a colonoscopy, all right, is negative. So this guy basically has Lynch syndrome. That is a problem with mismatch repair, but that's basically one of the guardians of the genome. It prevents um, it keeps repairing the DNA, and if it breaks, you're gonna like end up having mutations, and at some point, your these mutations are gonna be like in important genes, but and then you're gonna have cancer. But basically, what's lacking in Leach syndrome is the DNA mismatch repair, mismatch repair, microsatellite, and stability gene. B. Oh, the other ones make sense. All right, 63. Let's see how much time we have. We have 5 minutes. I want to get to like 75. It's 4 minutes. I'm not getting 75. 31-year-old, lump in her left breast. It's a female. Oral contraceptives. I remember this question. Has a freely movable nodule in her left breast. Corneal biopsy is performed. Which of the following has an increased risk of subsequent developing invasive carcinoma? Right. Okay, so you want to look for risk factors. Apocrine metaplasia. Important point. Metaplasia is always a risk factor except for one place, and that's apocrine metaplasia of the breast. It's not a risk factor for cancer. Blue dome cysts. It's not. It's one of the fibrocystic changes. I don't know what exactly it is, but it's not a risk factor. So what the answer you're trying to look for is one of the fibrocystic changes that has either hyperplasia or hyperplasia with atypical nuclei, right, or atypia. So and that's this one, right? Because sclerosing adenosis with ductal hyperplasia, right? It's got atypia and hyperplasia. Okay, so this girl, normal chromosomes XA, XX, high freaking blood pressure. So that means we are having mineral corticoids. That means the deficiency is at 11, because if it was at 21, we would have low mineral corticoids, right? We have low sodium, which means again confirming our mineral corticoid understanding that are high. Elevated androgens, because I mean, if you have 17 intact, you'll have elevated androgens. Um, so I'm gonna say 11 for this. All right. So 54 woman, uh, mm, loss of libido, menstrual. Okay, so she's going through menopause, right? Basically, with menopause, the way it starts is that the ovaries stop responding properly to FSH. So the what's it called? The pituitary will produce FSH, but these guys aren't producing estrogen. So what ends up happening is that you get longer cycles, right? Because that's what happened in the first part of the cycle. The first part of the cycle gets longer, so it keeps hitting the ovary. It just doesn't respond. So what you get is high FSH because of this guy, and then low estrogen because of this guy. C. C. All right. Oh, we got 1 minute. I'm gonna do it in the next one.